Welcome to this Paragon CRT certification session. My name is Ken Kopp, and we will discuss the information necessary for you to become certified to prescribe CRT to your patients. We will cover the lens design, initial lens selection, diagnostic evaluation, and troubleshooting techniques. Let's begin by informing you that Paragon Vision Sciences received the first overnight FDA approval for corneal refractive therapy on June 13, 2002. The approval included up to -6 diopters of myopia with or without up to 1 3/4 diopters of astigmatism. There are no age restrictions. We use the basis for our design work from the current understanding of corneal structure and the breakdown of corneal thickness. Through various studies that have been made over the years, we know that the only corneal layer that is affected by corneal reshaping using overnight lenses is the epithelial layer only. By altering the central curvature of the epithelium, the refractive power of the eye is reduced or increased depending on the procedure. Due to the epithelial layer being approximately 50 microns thick, there are limitations as to how much curvature change can be accomplished. What happens to the epithelium during overnight wear? At first, the theory was that cells were being redistributed from one area to another. This was found not to be true. What happens is there are certain areas where the epithelium is being compressed, while other areas are not. The fluids within the cells that are being compressed migrate to the areas without resistance and engorge the cells in that area, increasing the epithelial thickness. This epithelial change is easily seen comparing the pre- versus post-treatment topography. Let's begin with detailing the CRT nomenclature and design. There are only 3 main independent parameters that you have full control to manipulate for maximum success. The optical zone is 6 millimeters, and that is a fixed parameter. It does not change. Outside the optical zone is what we call the return zone, and that is also fixed at 1 millimeter. The last parameter on the periphery of the lens is what we call the landing zone. The most often used diameter is 10.5 millimeters. The only parameter that changes if a larger or smaller diameter is called for is the width of the landing zone. The treatment zone does not change with diameter alterations. The 3 independent zones are seen here in this profile. The first is the base curve or treatment curve, and it's measured in millimeters of radius. The return zone is measured in microns of set, and we will refer to it as the return zone depth. The landing zone is measured from horizontal, and it is measured in negative angles of degrees. Every lens is laser marked with the parameters on it. The laser markings on the back surface of the lenses allow easy confirmation if the patient is wearing the lenses in the incorrect eyes upon follow-up, or for you to make sure the trial lens gets back in the correct vial. The first 2 places designate the base curve. The second and third place designate the return zone depth, and the last 2 places are the landing zone angle. The base curve radius needed to eliminate the myopic prescription is purely a calculation. The lens selector is an easy tool to show the desired lens parameters for every prescription and keratometry combination. Unlike conventional gas perm designs, the base curve is never adjusted to change the overall fit of the lens. The next parameter is called the return zone, otherwise called the reverse curve with other corneal reshaping designs. The relationship between the front surface of the cornea and the back surface of the lens is precisely controlled by the depth of the return zone. The return zone is available in increments of 25 micron steps. In this example, you can see how overall sagittal depth would be influenced by these various return zone depth changes. The lower the return zone number, the sagittal depth is decreased and the base curve becomes closer to the central corneal surface. The higher the return zone number, the sagittal depth is increased and the base curve is positioned farther away from the central corneal surface. This slide shows how the tear pattern changes when changing the return zone depth from a deeper 575 microns to a shallower sag of 550 microns. The control of precise treatment is provided primarily by the variable return zone depth. The CRT lens is the only design that has the ability to alter the overall sag via changes in return zone or landing zone without affecting the base curve radius. This is termed proximity control technology. The third parameter is the landing zone. The landing zone is a flat surface with a radius of infinity. It can only meet the curved peripheral corneal surface tangentially. This tangential relationship between the landing zone angle and the cornea eliminates the possibility of impingement to the underlying corneal tissue commonly seen in older lens designs that have junctions to join curves on the posterior surface. The point of tangency can be moved closer to or farther away from the edge of the lens by changing the angle of the landing zone. While the base curve is a mathematical calculation and the return zone depth is a function of required treatment in corneal sagittal depth, the landing zone angle is available with different angles depending on the local slope at the mid-periphery. Remember, the landing zone angle is measured from horizontal. So angles below horizontal are always a negative angle. Excessive edge lift puts the point of tangency too far from the lens edge and the lens may be too loose. To move the point of tangency closer to the lens edge, thus reducing the amount of edge lift, the landing zone angle must be increased. This image shows the reduced edge lift result by increasing the landing zone angle by 1 degree. 1 to 2 millimeters of tear reservoir is the desired amount of edge lift. If the landing zone angle is increased 1 more degree, you can see that the point of tangency is too close to the lens edge and there is insufficient tear volume. This lens will most likely be too tight and adhere to the eye during overnight wear. The landing zone angle again controls the amount of edge lift and the overall sagittal depth of the lens at the same time. Observe the treatment curve and its relationship with the central corneal surface as the angle changes. As the landing zone angle is increased or decreased, the central sag is also being affected by the angle change. 1 degree of landing zone angle change affects the central sag by approximately 15 microns. Before we go into the diagnostic procedures, choosing the appropriate patient initially will make your life easier until you build confidence in taking on more difficult cases. Your first initial 5 to 10 patients should be either current soft lens wearers, spectacle lens wearers, which most often have been contact lens dropouts before. Keep the refraction and the keratometry within the moderate myopia range. Refraction should be under 4 diopters with less than 1 diopter of corneal astigmatism, and your keratometry should be between 41 and 45 diopters. Please do not attempt current gas perm wearers or patients who are currently wearing other ortho-K designs. Your initial patient selection will be built on solid, successful experience before you would attempt more advanced cases. A word of caution, please do not attempt patients that have over 0.75 diopters of against the rule astigmatism. Another good tip is that if the keratometry, when calculating the manifest refraction sphere and the flat K by subtracting the amount of myopia from the flat K reading, if it takes you below 38 diopters, this would be a patient that you would be hesitant to fit. You can only flatten the cornea so far. And lastly, please be careful about patients that have higher amounts of refractive astigmatism than the spherical component. The diagnostic dispensing system is the ultimate for initial lens evaluation and immediate dispensing for patient management. The standard system is available in a basic 100 lens or an extended 136 lens system. The 100 lens system has 10 base curves with various return zone, landing zone, angle combinations and will allow approximately 80% dispensability. The extra 36 lenses has 4 additional base curves in the flatter range for higher myopes with flatter corneas. There are only 2 pieces of data that are needed to calculate the initial lens parameters. One is the flat K reading and the other is the spherical component of the manifest refraction. Mean K readings or spherical equivalents are not applicable to lens selection criteria. Once these 2 pieces of information are available, use the initial lens selector rule to find the initial diagnostic lens parameter. Slide the tab until the arrow appears at the correct flat K reading. There are 2 rows of K readings. Make sure the arrow is pointed to the correct reading, either at the top or bottom row. Find the manifest refraction sphere to the right of the windows. The initial diagnostic lens parameters appear in the window immediately next to the manifest refraction sphere. In this example, we had a flat K of 4325, which would be indicated in the number 1 area. And if we go to the manifest refraction sphere, which is minus 350, the window immediately next to that tells us that we need an initial diagnostic lens of 8.6 base curve, a return zone depth of 550 microns, and a landing zone angle of minus 33. Once the lens has been selected, it's as simple as just putting the lens on, evaluating it with fluorescein, and you should have good centration. You should have a 3 to 4 millimeter treatment zone. You should have moderate tear film touch in the mid-periphery, 360 degrees, and appropriate edge lift. Centration is the key to success with CRT. One hint about diagnostic dispensing. Prior to the initial insertion of the diagnostic lens, it is advisable to instill a topical anesthetic. Now, this will control the amount of reflex tearing that you will have for the patient. This will also allow immediate and accurate sodium fluorescein pattern evaluation. In the DDS system, there are no duplicate parameters. If the candidate calls for the same lens in each eye, trial the called for lens in one eye, and for the other, stay with the same return zone, landing zone angle combination, but move to the next available base curve. Most often, it would be to the next flatter base curve. In this example here, we see that the called for lens is an 8.6 550-33, and because you don't have two of those, you would fit the fellow eye with an 8.7 base curve, but stay with the same 550-33 combination. Once the initial lens is on the eye, evaluate the centering of the lens on the cornea. If the lens decenters laterally or superiorly, that means that the overall sag is insufficient, and we need to increase the return zone depth one step or 25 micron increments until the centration is achieved. In this example, you see a lens that has a 550 micron return zone, and if it's superior or laterally displaced, going to a 575 micron return zone will center the lens and show you the appropriate fluorescein pattern. Conversely, lenses that are too deep in sag tend to decenter inferiorly. A common reason for inferior decentration is that the landing zone angle is too great, driving the lens downward from a superior, flatter cornea. Often, decreasing the landing zone angle by 1 degree will help in centration. Remember, any decrease in the number value of either the return zone depth or the landing zone angle will decrease the overall sagittal depth. So for inferior decentration, you first would want to decrease the landing zone angle 1 degree, or approximately 15 microns of sag decrease. If that doesn't seem to bring the lens to center, then step 2 is to decrease the return zone depth 1 step, or 25 microns. If the initial lens centers but does not provide sufficient central applanation, we will first check the amount of edge lift. If it's insufficient, then we will reduce the landing zone angle by 1 degree. If that doesn't seem to give us enough central applanation, we will then decrease the return zone depth in a 25 micron increment. Just a hint is that every time you alter a landing zone angle or return zone depth, always confirm centration with each parameter change. Evaluate the edge lift appearance. This slide shows the edge lift differences and the appropriate angle changes for excessive or minimal appearances. The picture on the left shows excessive edge lift. So what we would need to do to move that point of tangency closer to the edge of the lens, we will need to increase the landing zone angle. If the example in the picture was a negative 32 landing zone, we would go to a negative 33. The picture on the right shows insufficient edge lift, and we would need to decrease the landing zone angle to move the point of tangency away from the extreme edge of the lens. So if the example in the picture was a negative 34, we would move to a negative 33 landing zone angle. Excessive edge lift can cause decentration. So we want to make sure that we have the appropriate landing zone angle that gives us the desired amount of edge lift. Once you have evaluated the tear pattern and the positioning with the lenses on, perform an over-refraction. The over-refraction determines the accuracy of the treatment base curve calculation. And for this, we should note that your calibration of your instrumentation is essential to achieving a desired result. The overrefraction will also determine the existence of any residual astigmatism that may be coming through with the lens on. For best distance vision results, the overrefraction should be plano. Now, I'm going to divert from diagnostic evaluation for a moment and let you know that there are alternatives to the diagnostic dispensing system. One is the SureFit program and the other is a traditional warranty program. The CRT SureFit delivery system is a single-use 3-lens per eye fitting system. You have high probability of first fit success for easier patient candidates. The flat K readings are from 41 to 45 diopters, spectacle refraction of 4 diopters and below, and no more than 1 diopter of width of rule astigmatism. This is the best way to begin offering CRT to your patients if the DDS is not a purchase option for you at this time, but still allows you to have immediate or subsequent parameter changes without interruption of treatment. And it can be a valuable chair time saver. The other alternative is for empirical fitting. It's our traditional warranty program. You would order the first lens as selected from your lens selector guide using the flat K and manifest refraction sphere. And then once you have received the lenses, you have 2 additional exchanges at no charge within 90 days of the original order if necessary. Once you have dispensed lenses to the patient, let's move on to the proper follow-up procedures. The suggested follow-up schedule is number 1, after sleeping with the lenses on the first night. The next would be at the 1 week, then the 1 month, then the 3 month, then the 6 month, and then your annual exam. Always have the patient bring their lenses for you to inspect them for their follow-up visits. This is to check for proper cleaning and handling techniques. The first morning follow-up should be scheduled as early in the morning as possible. This will show the best topographical result. Also, if the patient can wear the lenses when they come in for that first morning follow-up, it shows you where the lenses are best positioned. You will first of all take a visual acuity with the lenses on again. You will perform a spherocylindrical overrefraction. You will evaluate the lenses in white light for position and proper movement. Then the installation of fluorescein and a cobalt filter will evaluate the tear pattern. Then go ahead, lastly, remove the lenses, check the visual acuity, and perform a topography. Why overrefract with the lenses on? Simple. It verifies that the base curve is correct and if there is evidence of residual astigmatism coming through with the lenses on. The desired overrefraction result should be plano. One word about autorefraction, and that it is not very accurate for lenses, for doing refraction with the lenses off. You will most often see more astigmatism through an autorefraction than you would subjectively. If there is cylinder coming through with the lenses on, that amount will not be correctable. If the initial refractive astigmatism is more than the difference between the flat and steep K readings, there will be residual astigmatism present. If you and the patient are okay with the visual acuity with the lenses on, then you may proceed with dispensing. If not, then discontinue and the patient will not be a candidate for corneal reshaping. The same power rules apply when altering the base curve. For every half diopter, the base curve would be adjusted by 0.10 millimeters. If your over-refraction is overly plus, you will need to steepen the base curve radius. In this example, we have an over-refraction of +1 sphere. If the base curve patient was wearing a base curve of 8.8, you will increase or steepen the base curve to 8.6 to achieve a plano result. Conversely, if your over-refraction is overly minus, you will need to flatten the base curve radius. In this example, we have an over-refraction of a -1 sphere. And if the patient was wearing a 9.0 base curve, we need to adjust and flatten the base curve accordingly to a 9.2 base curve. This will again result in a plano over-refraction. A word about treatment. The rate of treatment is not predictable. The average overnight treatment the first night is somewhere around 2 diopters. And the average treatment or transition period in order to achieve an all-day acuity with this treatment is 7 to 14 days. Now, the vision is always optimal with the Paragon CRT lenses on. So if the patient needs to put the lenses on, if they want to read or to watch TV before they go to sleep at night, they certainly can see exceptionally well with the lenses on. You might want to consider temporary soft lenses to use to manage their visual acuity during this first 1 to 2 week period during the day. Corneal topography is the best method of confirming the treatment position. There may be instances when the lens doesn't center properly in the opened eye, but topography verifies the treatment is well centered in a closed eye. The first mistake when performing that first day follow-up is to make parameter changes too quickly. If the lenses are displaced and the displacement is verified by topography, make the necessary parameter changes to recenter the lenses at that time. If the lenses and treatment are well centered and the over-refraction is plano, do not make adjustments for undertreatment until the first week follow-up visit. Let's review when it's appropriate to make changes. On that first morning follow-up, if the decentration is verified by topography, and if we have unacceptable visual acuity with the lenses on, that means either the lens power or the base curve is incorrect, or we have some surface or wetting issues. If the patient is uncomfortable and you find that you have excessive or inadequate edge lift, you have abnormal staining or even edema, or if the lenses are adhered, this is certainly the time to make the appropriate changes. And let's talk about when not to make changes. First of all, when the treatment zones are well centered, again, verified by topography, the over-refractions are acceptable, no minus, slit lamp examination is unremarkable, and the patient is fairly happy. Now, we know that there's going to be under treatment, but this is part of the initial process, and then wait until that next follow-up visit to check for under treatment. Proceed to the next schedule appointment with no changes when these instances occur. Now, let's talk a little bit about how you fix centration. On the first morning follow-up shows the lens treatment is decentered and again verified by topography. These are the parameters changes necessary to move the treatment to center. You do not have to withdraw the patient from treatment to make these changes. If you have the correct additional lenses at your disposal, dispense the new parameters and schedule the next follow-up visit. For superior or lateral decentration, the first thing we're going to do is to increase the return zone 1 step or 25 microns, but stay with the same landing zone angle. The example here is if your initial lens was a 550-33, we're going to change to a 575 return zone with a 33 landing zone angle. If that doesn't bring the lens to center, now we're going to increase the landing zone angle 1 degree, but stay with the same return zone depth. And lastly, if that doesn't seem to bring the lens to center, you need to call your authorized Paragon CRT consultant. If we have inferior decentration, again verified by topography, we're going to decrease the landing zone angle 1 degree and stay with the same return zone depth. Step 2 would be if we still didn't move the lens to center with the landing zone angle only, now we will decrease the return zone 1 step, staying with that decreased landing zone angle. Here we see slides of the edge lift appearance, and if it's insufficient with the -33 landing zone angle, in order to move that point of tangency farther away from the edge of the lens, we're going to decrease the landing zone angle 1 degree to a -3.2. If we have excessive edge lift with a -31 landing zone angle, we need to move that point of tangency closer to the edge of the lens, so we're going to increase it 1 degree to a -32. Once you have a few successful patients under your belt and wish to attempt patients that will be a little bit more of a challenge, take this 2-step procedure under advisement. Higher myopes will require deeper sags than what is initially suggested in order for the first lenses to center properly. Choose a return zone depth that is 25 microns higher than the suggested base curve and landing zone angle. Once the patient has worn the lenses for 1 or 2 weeks, and if there is any undertreatment remaining, we can then reduce the overall sag to eliminate the undertreatment. If you have the 100 lens diagnostic system and find that your patient base has flatter corneas, there is an extended base curve set available at the reduced diagnostic price. Another diagnostic design that is available for patients that display higher amounts of corneal astigmatism, meaning greater than 1.75 diopters, is called the CRT dual axis. It has 2 separate return zone depths and/or landing zone angles to mimic the shape of the astigmatic cornea. Another helpful aid in fitting CRT is the CRT software. This program takes the data from the pre-treatment map, and when you enter the prescription, shows a simulated tear pattern for the standard CRT design and the CRT dual axis design at the same time. You choose which you think will work best for the patient. This software is available with certain topographer brands. It's for the Medmont, the Keratron, Oculus, the Atlas 9000, and Tomei versions 1 through 4. There are direct links available with the Medmont, Keratron, and Oculus models. Electronic ordering is also a feature of the software. This concludes our training program. Congratulations on reviewing the certification information for the CRT lens. Now you must complete the short quiz. Once completed, you will receive your own certification number and certificate of completion so that you may begin ordering for your patients. I thank you for your attention.